Hello, I'm a specialist MSK physio working for Circle Integrated Care, providing MSK services in your area. This is a short educational video on imaging and lower back pain with or without sciatica. During this video, I will be covering elements from the NICE guidelines on the management of those patients presenting with lower back pain with or without sciatica. The aims are to improve the MSK referral information quality, to enable better triage decisions. This can be done by including appropriate subjective and objective information to inform appropriate triage outcome. Secondly, to improve patient understanding and beliefs, preventing misconception of lower back pain with or without sciatica and the need for imaging. This can be done with shared decision making, allowing for better discussion of the presentation and signposting to appropriate patient information. And thirdly, to improve patient outcomes and care experience by ensuring correct patient pathway first time. Overall, avoiding delay to recommended treatment will minimise pain chronicity, fear avoidance, and biopsychosocial impact. Subjective and objective information. Establish the onset and nature of symptoms, whether improving or worsening. Whether there was gradual or sudden onset, or whether in keeping with chronic presentation, and also include whether there's previous failed conservative management. Look at mechanical, whether worse with use, better with rest, whether thinking more inflammatory, i.e. whether better with use, worse with rest. Look as to whether there's any neural changes, pins and needles, numbness, whether altered sensation actually follows a specific lumbar dermatome distribution. Look at sensitivity to stretch, i.e. the straight leg raise, but bear in mind if this is greater or equal to 70 degrees, it's not clinically significant. Assess myotome weakness, establish whether myotome changes correlate to the pain presentation or whether weakness is due to pain inhibition, and look for any abnormal reflex or upper motor neural changes, comparative to both sides, whether there's down or breast response, a clonus pattern of greater or equal to 5 beats, a Babinski normal down response. Include relevant past medical history, such as cancer, neurology, peripheral neuropathy, inflammatory. Also considering the start batch tool, which is the risk stratification tool to assess recovery of outcomes, and can inform whether patients would benefit more from a combined physio and psychological approach to management. Finally, exclude any suspected metastatic spinal cord compression, infection, fractures due to trauma, or signs of cauda equina, as these are not for MSK. Here are some useful resources to help shared decision making and to support self-management. They can be accessed by clicking on the links below. In primary care, for acute back pain with or without sciatica, offer reassurance, consider analgesia and discuss timeframes for recovery. Direct patients to first contact physio for acute presentation with the importance of patient reassurance and education to encourage normal activity. Do not routinely offer imaging in primary care. Common acute low back pain with muscle spasm plus or minus nerve irritation can self-resolve within 2 to 6 weeks and up to a few months, so does not require early MRI imaging. Early MRI for non-red flag presentation prevents early access to treatment. This can delay recovery, increase chronicity, and can cause more harmful effects to patients' beliefs and expectations. See the helpful resource below from BEST MSK, which offers clinical advice for clinicians to aid decision making for MRI. Refer to physio for those patients not responding with simple analgesics and exercise. There are different physio platforms available that include one-to-one face-to-face, Escape Backs, which is a group rehab approach, Joint Academy, a virtual rehab approach using a technology interface, and iBest for those patients needing more of a combined rehab and psychological therapy input. Do not offer acupuncture as there is no evidence to support this for the management of lower back pain with or without sciatica in accordance with the NICE guidelines. Do not offer spinal injection for simple back pain without sciatica, as this is indicated to improve leg pains and not back pain. If being referred to the MSK service for further management, they may not need imaging if there is no hard neurological findings and have not tried conservative management. MRI findings need to be interpreted with correlating clinical examination prior to considering a specialist input. As there are known incidental age and activity findings on MSK MRI, only if there is significant nerve compromise and correlating neural findings is a spinal specialist opinion sought. Please see an overall visual summary from the NICE guidelines. It is a useful algorithm to help management of this patient group that is evidence-based, has specific recommendations to assist those if management is not clear, and reiterates clinical indication when considering imaging. Overall, we want to ensure patients are given best evidence-based treatment first time, thereby avoiding delay and improving patient outcomes by minimizing pain chronicity, fear avoidance, and biopsychosocial impact. Here is a list of references and useful resources. We have other videos available on our website, so please check them out. If you would like to see any other MSK topics covered, then please contact your local Circle MSK service. Thank you.